Hello, welcome to our medical series called To Care by Sanford Health. I'm your host, Courtney Collin with Sanford Health News. Call to Care brings forward medical experts who can give fellow clinicians some advice and guidance that they can use in their primary care practice and information about when it's time to refer patients and families to more specialized care. Joining me for these conversations is Dr. Joseph Sejuan, who is Vice President and Medical Officer for Sanford Children's Hospital and a leader in pediatric critical care. But he's here as my co-host, if you will, to help us dive even deeper into a lot of these topics and provide the best insight and care for our patients and communities. Dr. Sejuan, good to have you back here.
Courtney, it's wonderful to be here. It's good to see you again.
So our topic today really is fascinating, focusing on regenerative medicine. Orthobiologics at Sanford Health is treating musculoskeletal injuries through cells from fat, blood, bone marrow, which can reduce a patient's pain, speed up healing, improve overall recovery. That's really all I know about this. So I'm excited to dive even deeper with you and with our physician expert who is joining us, Dr. Donella Herman, who specializes in non-surgical orthopedic conditions, including fractures, arthritis, overuse injuries in endurance athletes, and concussions through a variety of treatments. Dr. Herman, welcome.
Hi, thank you so much for having me. It's a pleasure to be here today.
We're so glad to have you.
Yeah, I tell you, Courtney, I share your perspective on this. When I was prepping for this session, I really came to realize how much I did not know about this subject. And so I'm sure our listeners are also quite excited to learn about this. So Dr. Herman, again, thank you so much for being here. We really look forward to our conversation that's upcoming. Why don't we start off by telling us a little bit about yourself and your training?
So I have been working at Sanford Health for the last 4 years. I kind of took a roundabout way to get into my medical training. I was actually previously an athletic trainer and then did some fetal alcohol syndrome research and then decided I wanted to kind of pursue medical school. I kind of had a natural draw towards sports medicine and research at that point, given my background. So I went to medical school at USD, and then I did my family medicine training here in Sioux Falls. After my family medicine training, I did a year fellowship at Duke University in North Carolina. That sports medicine fellowship focused some on research, a lot of ultrasound-guided injections, the overall treatment of musculoskeletal injuries, including fracture management, and then also some additional training in kind of the regenerative medicine realm.
Great. Well, fantastic. Thank you. And we really are so fortunate to have you here in our region. So why don't we just get to it? What are orthobiologics?
So orthobiologics is kind of a big fancy word, and it's an umbrella term that we use in terms of how can we use our body's own resources in an attempt to provide a better environment for healing. And a lot of times there's kind of the fancy words that you hear in the news about how we're going to regrow things and the stem cells. For us, it's really, we're trying to find ways to use cells that we have that we know are a part of the healing process. Things like platelets, things like mesenchymal stem cells, things that we know help in the healing process when we have an injury. And how can we harness that for some of the everyday things that we see in our clinic? And so that's kind of what orthobiologics is as a whole. It's just kind of harnessing the body's own resources and trying to utilize those to improve an environment and promote healing.
So is orthobiologics a part of regenerative medicine, or is it different from regenerative medicine?
So it's kind of, it depends on where you are. It's kind of a regional term, more or less. Some people will call orthobiologics regenerative medicine. Some people will call regenerative medicine orthobiologics. I see it more as orthobiologics is a small area under the umbrella of overall regenerative medicine, because we can use regenerative medicine in cancer treatments. We can use it in other diseases as well. The orthobiologics, we are focusing that on musculoskeletal injuries versus kind of whole body treatment.
Okay, perfect. That's very helpful. Thank you. That really clarifies it for me. In thinking about what's the best way to sort of unpack this topic, perhaps maybe we could start with what kind of patients come to see you specifically for this technology, and then maybe we can drift into the actual technology itself.
Absolutely. So I see a wide variety of patients in my everyday clinic. When it comes to the regenerative medicine and orthobiologics portion of my patients, it really is people who likely have a chronic injury. Osteoarthritis is one area that we treat pretty extensively with orthobiologics. But we also have things like chronic tendon injuries, whether it be rotator cuff or Achilles tendon. With that being said, you can also use some of this for acute injuries or injuries that maybe we have an athlete that has an acute injury to the rotator cuff or to a muscle, and using these products, we can try to expedite healing, get them better faster, kind of a mentality, but also do it in a safe way where we know we're promoting maximum healing.
Yeah, I was surprised when I was prepping for this. In 1939, there was a bone marrow aspirate used for non-union fractures. So I don't know. I don't know if I was doing a crossword puzzle in medical school during that period or what happened. But very interesting. So chronic injuries, and I know chronic conditions like osteoarthritis affect something like 50 million people, knee osteoarthritis in the United States. What are the advantages and then disadvantages of the orthobiologics, or if you'd like to get right into the usages of whether it be plasma-derived products or stem cells, it's really up to you.
Yeah, I think that one thing that we're focusing on, and a lot of people focus on with orthobiologics, is it's a non-surgical option. We're looking for, right now we have steroid injections, or we have lubricating injections, or we have things that are man-made that we can inject, and then we have surgical options, and there's not a lot in between. And so these are kind of seen as conservative measures that aren't quite as invasive as a surgery, although I will say that bone marrow aspiration is not a uninvasive procedure, but it's kind of something that, okay, if we don't want to go in and surgically intervene or have a joint replacement, we kind of see these as options of that kind of gray area where, because it seems like we go from really conservative stuff and then don't have a whole lot in between that big surgical intervention. And so for us, this is hopefully going to help bridge that gap. But there are different kinds of cells that we can utilize to try to bridge that gap. And the probably less invasive thing to do is to use a blood product. So you can have your blood drawn. We spin it down in our clinic. We take platelets, and sometimes we add some white blood cells in if we're going into a tendon. But we use those platelets and we inject that into the injured area, whether that be a joint or a tendon. And the hope is that those platelets, who are the first cells at the scene of the accident, is what I always tell my patients. You cut your fingers and the platelets get there first and signal your body what to do. Well, we anticipate that these platelets, we put them in a concentrated amount into a joint space or into an injured tissue, and they're going to signal the body, hey, let's have you come in here and bring some healing in, or bring the products we need to promote healing. And it's really about trying to create that better environment for that joint or for that injured area. And so that's kind of a less invasive way to do it. But then, okay, the next step, maybe we want to do something more with the regenerative cells that we get from bone marrow or from fat. And so for those, we have a little bit more invasive procedure, but we also know that the mesenchymal stem cells also have a lot more signaling power than a platelet does. And so we can go in and do a bone marrow aspirate off the back of the pelvis, and then we have a process where we clean the cells and we count the cells. We make sure they're alive. Most importantly, we see how many we have. We also make sure that there's not any toxins in there, and we make sure there's nothing infectious in there. And those kind of 4 steps are something important, because that's not something everybody does. And so we make sure that we know what we're injecting and that it's a safe product to inject, and then we inject it into the injured area. We can also get those same sort of regenerative cells from fat tissue. And so we can go in and do basically kind of what we call a mini lipoaspirate, or a small volume liposuction. And so we do that either off the abdomen or the gluteal areas. And we take those cells, and they have the same, a different processing standpoint, but we are looking for the same things prior to injection. We want to make sure they're safe. We don't want any toxins in there. We want to make sure that we have live cells and that there's enough of them that we're actually going to get a good response from it. When using these cells, it's the same thing. I'm not going to promise you, we're going to come in and regrow new cartilage. We just don't have evidence of that yet. But we do know that if we inject these things, people have improved pain. they have improved function, and they're able to do the things that they enjoy more often. But we're also following that with all of these regenerative cells. We are following our patients so we know how long they're having relief for, how much activity they're doing, if they have improvement of pain and motion. These are things that we're following them and kind of measuring. Because right now we don't have a lot of information. There's a lot of people doing it all over the country. You can go anywhere and there's kind of pop-up shops that are offering these stem cells or offering, they're making a lot of promises that we can't necessarily say they're delivering on. And so what we're trying to do is hopefully in 5 years, people will come to Sanford and say, in a patient with this condition, which product works the best, and we'll have that information. We'll be able to say, yeah, we've done all 3 products in this kind of an injury or this kind of a population, and this product seems to be working the best. And so that's kind of our overall goal with it.
I know I read in prepping, the stem cells are viewed as the general contractor coordinating the repair job, and the plasma-rich or platelet-rich plasma are supplies added to do the job. So, I thought that was, or supplies needed to do the job. So I thought that was interesting. So most of these treatments are symptom relief. Is that accurate?
It's symptom relief and functional improvements.
Okay.
And so we do generally want to see less pain, but we also want to see improved range of motion, improved strength, and improved overall function. And so those are all the things that we follow. We have a way of capturing patient-reported outcomes for our regenerative medicine orthobiologic patients. And in doing that, we're hoping to see maybe, again, in 5 years, we'll find out that this one helps most with pain. So if their primary problem is pain, we should probably go in this direction. But if we're really looking to get back to doing more high-level activities, then we'll hopefully be able to steer ourselves and our patients in the right direction.
And when you talked about duration of effect, does that vary with product? Does it vary with the injured area? Or can you comment on a little bit of, is there preliminary data that gives you an idea of what the duration of effect is?
It's kind of hard to predict, and it's kind of like the other options we have currently that are widely used, like the steroid injections and the viscosupplementation. We know that some people get the injection and it may last for years, and some people get the injection and it may last for months. And so it can be a little bit difficult to predict, but I think that there's been some data showing that, 6 months out, people are still seeing improvement with the regenerative cells. I know that there are health systems and health insurance plans that do cover some of the platelet-rich plasma injections for joints, and they can allow them up to twice a year. And so kind of, again, that 6-month mark is what we're kind of seeing for improvement. With that being said, anecdotally, I can tell you of people I know that have had the regenerative medicine and orthobiologics, and they have had years of relief and have significantly improved their function.
Okay, that's good to know. I know that there are differences with regards to what's allowed with the cells prepped and the length of time between aspiration and injection. And I get the sense that much of this is FDA and legal, that is specific to the United States, and then also perhaps different rules or different legalities pertain to outside the United States. Can you comment a little bit on that? Yeah,
the FDA has some pretty strong statements in terms of minimally manipulated cells. That's the term that they like to use. And so that gives us a window of time of processing these cells and injecting the cells, and also what can you mix together and what can't you. And so there's restrictions in terms of taking a couple of products and putting them together and seeing if we mix them, is it better? Well, that's kind of, we're manipulating things at that point, and so things have to happen in individual injections. There has recently been some kind of more robust statements from the FDA in terms of they want to restrict kind of the places that are maybe trying to take advantage of the, what's the word I'm looking for? this is the new sexy thing to do, and you hear about it on the news, and you have pop-up ads, and they're treating you to dinner and telling you about this product, and it gives regenerative medicine and especially orthobiologics kind of the snake oil salesman feel. Yeah, they're kind of schmoozing and kind of making a lot of promises that we can't really back up. And so the FDA has come out with a lot of some strong statements in terms of, one, we obviously don't want to manipulate the cells. That's always been the rule. But also, if you're doing this, you need to make sure that you're doing it appropriately, that you're doing it for the reasons of collecting patient-reported outcomes and in ways that the FDA says it's okay to do that. One interesting thing of the stem cells or the regenerative cells that we're utilizing is that for the fat-derived stem cells, we have an FDA registry for that. We're the only place in the country that has an FDA registry. So really, nobody else should be injecting these processed cells for joint pain or for osteoarthritis in the 5 joints that we have the registry for. But the reason we have the registry is because it's something that's kind of needed right now in medicine because there are so many other places doing it. We need something that's controlled, but it's hard to do a double-blind, randomized controlled study for every single joint, for every single thing. So they're asking us to kind of start with the registry and then get some preliminary data from that and then see from there if we can kind of, okay, what can we use for head-to-head studies thereafter? But it's going to give them a lot of information in terms of what they can be used for in the future. But that also means we have a registry and we're being watched. And so you know that we have a lot of safety measures in place. We have a lot of rules that we need to follow, especially our processing. And this is something that even with the bone marrow-derived regenerative cells, you know, we have a window. We want it from the time we start processing the cell to the time we inject it, we want to get that done in less than 2 hours because we want to have the highest cell viability. We want as many cells to be alive as possible. We want the least risk of it being, you know, contaminated by something. And so we try to get everything done within a 2-hour window for the regenerative cells from bone marrow and fat. For the PRPs, we inject those within 20 minutes. I mean, it's 20 to 30 minutes between when we draw the blood because we do it directly right there in clinic and it's a blood draw, so it's a little less invasive.
I can certainly see with the huge number of individuals who are affected by osteoarthritis, by injuries, orthopedic problems, I can certainly see where there's a need for this. And I can also see where there might be some opportunities for people to take advantage of people that are vulnerable and that have chronic pain syndrome. So I'm delighted to hear that Sanford is part of clinical trials and really leading the way domestically with this registry. I think that's fantastic. Let's talk a little bit about cost. You alluded to earlier that some insurance companies cover this. How do most patients afford this, or is cost prohibitive? Or
it can be for some patients. I say some health insurance plans. Sanford Health Insurance covers the PRP injections to the knee, and that's one of the few that does. They just cover it for knee osteoarthritis at this point, but we're hoping that eventually we'll be able to expand that to other joints as well. A lot of insurances don't cover it, though, because it's still considered to be an investigational use. And so until we get consistent data, and that involves everybody actually collecting the data, until we get that, insurance companies are really hesitant to cover for it. With us having the FDA registry, we're not here to make a profit. We can't make a profit if we have an FDA registry, but it does cost money to do these. And so for all of the orthobiologics procedures, we do what we call cost recovery, which is basically that we have the patient pay for it, but it is basically covering the cost of the procedure and the injection, and so it's not anything that is necessarily for profit for Sanford. It's really we're just trying to cover the cost. If you're doing it into a joint, oftentimes it requires more than one injection. So we're doing usually 2, sometimes 3 injections into the joint, so that can add up. For the tendons, with the platelet-rich plasma, we can generally get by with just doing 1. That has a little more restriction afterwards. You know, if we inject into a joint, people usually get back to their regular stuff pretty quickly. With the tendons, we have some restrictions afterwards, but we can generally do that as a one-time injection.
Okay, thank you. I do want to go back a little bit to the physiology and the science of this, if you will. I understand that cartilage, because it has very little blood supply, does not really heal very well. Mm-hmm. And that's one of the attractive features of stem cells. Is that correct?
That's one of the attractive selling points for stem cells, I'll say. I know that there's been some studies in the past that have shown that there have been cartilage defects that have had improvement after stem cells. I don't think it's necessarily the same kind of cartilage. You know, we have this really robust cartilage at the end of the bones on those weight-bearing bones. We certainly don't make promises that we're going to rebuild cartilage because we just don't have evidence that that's what it's doing. For me, I prefer to think of it as we're just creating this environment where we have these signaling. And, you know, for me to say if I put a stem cell into your knee, it's going to regrow cartilage. Well, if I say it can do that, I don't necessarily think I can say that it won't turn into an ear. You know, I mean, we have, we think that the stem cells can just figure it out that quickly. For me, it's more that we're putting the stem cells in there. It's in this environment, and it's creating a better environment where the body can come in and kind of heal the area. And it's probably not going to put down this big, robust cartilage, but it may create an environment where there is some protection for where the cartilage has worn through.
Okay, thank you. That's very helpful. Let's talk a little bit about what we're doing here at Sanford. Why don't we? Let's just talk about what in your practice. What's your typical day, or how are you applying these orthobiologics to your practice?
I love my practice because I don't have a typical day, but you know I'll see a wide variety of young people to 6, 7, 8 year olds to 96, 78 year olds. But when it comes to the orthobiologics, a lot of the times the people I'm seeing are people who it's either an athlete who has had an acute injury and we're trying to get in there and promote maximum healing quickly, or it is somebody who has had a chronic condition who's looking for a non-surgical option. Generally what we do, we have them come in. If we need to get some imaging, we do. A lot of times they have some imaging. But we kind of look at their underlying issue and talk about all the things that they've tried, and then kind of talk about the differences in orthobiologics. And based on our kind of conversations and their goals and expectations, we decide what the next best step for them is going to be, and whether that's a regenerative cell or if it's more the platelets. We can kind of determine based on, cost. Is that going to be prohibitive, or is it going to be difficult for you to be laid up for a few weeks if we inject a tendon? Things of that nature. It's really an individualized conversation with each patient about what their overall goals are, expectations, and how orthobiologics can assist them in the most meaningful way.
I think I heard you say that there were 5 joints. Is that correct?
Yes.
What are those?
For the fat-derived stem cells, we have 5 joints that we can utilize. We have the wrist joint, the shoulder, the hip, the knee, and the ankle. Okay. When we do the bone marrow-derived stem cells, if you have let's say you have some arthritis in your hand or in your midfoot, we can utilize those for other joints as well. So there's a little bit broader use for the bone marrow derived cells. We can also use those cells in things like rotator cuff tears and tendon injuries.
Okay. And are these procedures that are typically same-day procedures?
Yep. I usually tell people if we're going to do the procedures for the regenerative cells, either the bone marrow or the fat, that you should plan on giving me half of your day. And so we have you come in either early in the morning and we get you out by lunch, or we have you come around lunchtime and we have you out by 5. Like I said, we want that kind of short processing window. We don't want too much time to go by. And so it's usually kind of an in and out procedure for them.
Okay. And what about recovery?
Recovery for the tendon injuries, that's a little bit longer. We do a little bit more to protect tendons than after the injection, because we create this inflammatory response, and we don't want to start pulling around on that tendon. So for that, I tell people, at 6 weeks after that injection, we're hoping to get you back into those higher level activities that you enjoy, or sport specific activities for an athlete. For joints, we tell people we kind of just, it's kind of common sense. For the first couple of weeks afterwards, just don't overdo it. Kind of reduce your impact activities, or if it's a shoulder, don't do a lot of overhead stuff. But if we're going into a joint, it's kind of 2 weeks of let's take it easy and not overdo it, and then gradually try to increase your activity after that.
Okay. Well, it seems like this field of orthobiologics, I've heard so much about it, particularly in the last 5 years or so. So I'm gonna have you do some predictions here. What does the future hold for this field?
I'm hopeful that in 5 years we'll be able to say we have other options for people who are either not surgical candidates, because there's people with comorbidities that just don't have good surgical options, but that we also in 5 years maybe have a better understanding, that we're starting to glean more of that information of, you have this kind of a problem, you're in this age group, you've tried A, B, or C, can we start, what's going to be the best option for you and where you're at in your life with this condition. I'm hoping in 10 years we'll be able to say, you know what, maybe we should be doing this earlier. Maybe we shouldn't be doing as many steroid injections. Right now, people are getting in as they run out of options. Maybe in 10 years we'll realize that maybe this is an earlier option that will kind of give us additional options moving forward. So that's what I'm hopeful for, is that in 5 years we'll have a better idea of which patients fit where, and in 10 years we'll be able to say maybe we need to start sooner.
Okay. All right. And finally, can anybody refer patients to you, and can patients self-refer to you?
Absolutely. So if patients have interest in orthobiologics, they can certainly make an appointment with our clinic. They generally try to funnel them to me so we can have that individualized conversation. But sometimes they come from other people within our clinic if they have interest and mention it to another provider. If you're a provider outside of our clinic, we actually have an orthobiologics referral within the Epic system. So if you just type in orthobiologics, that referral will pop up. You associate the diagnosis, and it will get them directly to my clinic for the conversation.
Okay, well, great. Well, I know the time seemed to go quickly. This seems like a topic that we could wade into for hours, but I hope this was a good overview. Is there anything that I left out that you'd like to comment upon?
That, it's an exciting time for orthobiologics. I'm really proud to be a part of it at Sanford, because I do feel like we're doing it right, and that's kind of always been our like mantra within the orthobiologics group, is that if we're going to do this, let's make sure we're doing it right. And I think that we have a really unique opportunity to not only provide the best care for our patient population, but also to develop information that can be used across the United States and the world in terms of how orthobiologics could be used and should be used moving forward.
Well, I appreciate your scientific integrity, and I certainly appreciate all that you do clinically, and I really appreciate educating Courtney and I on this topic, because I learned a lot. So I'll turn it back to Courtney.
I learned a lot too, Dr. Tsejalon. Thank you as always for being here again to help guide the conversation as we speak to our clinician experts in this space. Dr. Herman, wonderful to meet you and learn more about your practice and the healing that you provide for patients with pain. Thank you again for being here.
Absolutely. It was my pleasure.
Our Call to Care podcast series by providers for providers continues right here with our Sanford Health experts. I'm Courtney Collin. Thank you so much for being here. We'll see you soon.